Alright, Chapter 45 on soft tissue trauma. When we look at the epidemiology of soft tissue trauma, it is the fifth leading cause of non-fatal injuries in the United States. Those risk factors include smaller children and the elderly. Remember, falls are the number one cause of death in the elderly. Industrial settings, particularly in some careers, are at higher risk of entanglement into heavy equipment and machinery, and persons with chronic illnesses again don't do well with trauma, period. To prevent trauma, as we've said all along, it's education. Probably one of the bigger concerns with soft tissue trauma is that soft tissue trauma is soft tissue. And there's going to be some bleeding, and of course you always must be concerned about the potential for bloodborne pathogens. So make sure that you have your personal protective equipment and that you dispose of soiled material properly. Here there's giving you an example of disposing of sharps in a little portable sharps container. When we talk about soft tissue trauma, we're going to talk first about the skin. The skin is there as a barrier to prevent water loss, to keep bugs out, and to keep the heat in. It regulates body temperature by evaporation of sweat. Within skin are located the sweat glands, and when sweat is brought to the surface of the skin and evaporates, it pulls with it a tremendous amount of heat. So that's one way of dissipating excess heat, is by evaporation of sweat. Skin consists of the epidermis, which is the external layer. It's constantly developing new cells, and they eventually shed. And as we age, of course, the cosmetic appearance of our skin changes as we lose things like collagen, moisture, and our skin thins. The dermis is below, of course, the epidermis, and that's where your sebaceous glands are, your hair follicles, your capillaries, your nerve fibers, some of your connective tissues like cartilage and those sort of things. But also circulating within that tissue are things like mast cells, fibroblasts, macrophages, and neutrophils. Mast cells being related specifically to allergies, and neutrophils being a type of a white blood cell. You've got your superficial fascia, and this is the connective tissue that surrounds your subcutaneous fat. And then you've got your deep fascia, or fascia, which is a thick, dense layer of fibrous connective tissue. It's the final layer of defense against infection and internal structures, and it helps support your underlying anatomy as well. We also have to consider joints when discussing about soft tissue trauma. You have synovial joints. Synovial joints allow an extensive range of motion. That's where two bone ends come together. They may be tied by tough fibrous ligaments, and those joint capsules may contain synovial fluid. Tendons connect muscle to muscle and muscle to bone, and they allow muscle to move the bones. And here's just an example of the different muscles as well as the different ligaments and tendons of the knee. Here's an example of a synovial joint, again, where you've got that capsule filled with synovial fluid. When injury to that particular part of the body occurs and you get some soft tissue swelling in the joint, it can be very painful and may even have to be drained. Normal wound healing requires homeostasis. It requires all the internal workings of the body to be in check. Your temperature needs to be within a certain range. Your pH needs to be within a certain range. You need plenty of oxygen, and your CO2 needs to be in a certain range. Normal wound healing begins with coagulation. Coagulation is the process of forming clots. So when I have a soft tissue injury, I might bleed, and I need to coagulate to stop the bleeding. And that involves platelets, which are very irregularly shaped cells. Platelets bind with platelets and they begin to form a plug in the damaged vessel. And then the fibrin, the rich red fibrin, weaves through those platelets and causes a clot. Injured capillaries also have a tendency to constrict in response to the the assault on the body. Any sort of injury leads to some release of epinephrine and norepinephrine, particularly if there's any pain involved. Histamine release also occurs as part of normal wound healing. It's the inflammatory phase of healing. The capillaries are dilated. It rushes more of the fluids necessary to help with healing to that location. Those dilated capillaries then undergo what's called increased vascular permeability, and they may leak into the surrounding tissue, causing obvious swelling. You've got granulites that help with wound healing, as well as macrophages that help eat up and get rid of debris, dead cell debris. Following an injury, there's because of the inflammatory response of histamine and the dilation of the capillaries, the extremity will often feel warm, may also begin to swell. Epithelialization, neovascularization, capillary buds, all those things are part of the normal healing process, part of rejuvenating or filling in a particular wound. And a chemical called hydroxylysine helps strengthen the new tissue as well. Some things that might interrupt wound healing include poor circulation to the areas. That's going to delay the healing. Foot wounds are at high risk of infection because of a couple of reasons. One, the poor circulation, and the fact that feet are often, full of quite a bit of bacteria, particularly if you walk around barefooted. If the wound has really good perfusion, it's going to heal well. High tension areas over joints where the skin is stretched every time you move that joint will delay in healing and often cause scars to form. And again, the condition of your skin, whether it's dehydrated, lacking collagen, whether it's extremely thin, all those things are factors that interrupt wound healing. If you're taking drugs that inhibit the inflammatory response, that's going to interrupt wound healing, which is going to increase the healing process time and also increase your risk of infection. There are medical conditions and disease that are going to interrupt in wound healing. They include being advanced in age, alcoholism, acute blood infections, diabetes because of the neuropathy and the poor circulation, severe anemia, peripheral vascular disease, cancers, liver failure, heart disease, and smoking because of the vasoconstriction and the rise in CO2 and lack of oxygen. Some high-risk wounds include human bites, dog bites, cat bites, and foreign bodies. Of those, probably human bites are the most infectious. It's not that dog bites or cat bites are cleaner than human bites. It's just that dog germs are germane to dogs, where human germs are germane to humans, and a human bite is has a greater potential for infection than a dog bite. Wounds with significant devitalization or devitalized tissue or significant tissue destruction include entrapment in some agricultural equipment or entrapment in industrial equipment, any sort of crush mechanism, high velocity weapons, dragging or sliding at high speeds on the pavement, and the wounds themselves, because of the tissue, it may have to be cut away or debrided in order to prevent necrosis and gangrene setting in the tissue. Immunocompromised patients are at high risk for infection. So those with advanced cancer, those with rheumatoid arthritis, those with an autoimmune disorder like lupus, diabetes, um, and of course wounds are worse if they're located in an area of poor perfusion, particularly in these type of patients in the below the knees. Um, Regardless, if there is a soft tissue wound in this group, it should be evaluated by a physician. We've already mentioned how hypoxic tissue will delay healing, but it also encourages the formation of pathogens, and pathogens are what causes disease in people. Um, you can get DVTs, peripheral vascular disease, diabetes. All those things increase the risk of infection, and then just general infections themselves. Um, Scarring differs from one person to the other. We all don't scar the same way. A keloid scar is an excessive accumulation of scar tissue. It extends beyond the original wound borders. It's darkly pigmented. You'll see them in the ears, in the upper extremities, the lower abdomen, around the sternum, and if they're cosmetically an issue, or if they're improperly healing, they may be managed with surgical procedures or steroid injections. And here's an example of keloid scars. Some wounds develop abnormal levels of scar formation, include hypertrophic scars. And hypertrophic scars are the most common. It's just an excessive amount of scar tissue, but it remains within the borders of the original wound. It may be slightly raised, and we see these evolve or develop in high tissue stress areas. And so below the lip there is an example of a normal type of scarring that we see. Wounds requiring closure include cosmetic wounds around the face, the lip, the eyebrow, gaping wounds, wounds that occur over tension areas like joints, degloving injuries, ring injuries, skin tearing, avulsions may be significant enough to require wound closure. Wounds that do not require closure include superficial wounds. They may be able to treat and release the patients. It's important that we do inquire about their tetanus vaccination. They should have a tetanus vaccination at least once every 10 years, at least once every 5 years if they're prone to injury. Educate patient on how to clean the wound with warm soap and water, maybe some hydrogen peroxide, and if you don't transport, contact medical direction if in doubt. Some different types of injuries include contusions. Contusion is a rupture of the small blood vessels and damage to the cells within the dermis. It's evident by the appearance of ecchymosis, which is a bruise. Deep muscle tissue or organs do not always produce ecchymosis or swelling. Hematoma is a blood tumor. Large amounts of tissue damaged, or large veins or arteries are ruptured beneath the intact skin, causes a big pocket of blood to form. If the blood is greater than 1 liter or more, it's going to require some management. A sprain is a very common joint injury. That's where you stretch or tear the ligaments. It often occurs during sports, and it's difficult to diagnose in the field from a strain or even a fracture. Strains is a muscle or tendon injury. It's caused by a sudden explosive activity. You see it in athletic patients, in motor vehicle collisions, falls, assaults. There are going to be some pain, swelling, and bruising and warm to the touch around the joint. And again, it's often very difficult to differentiate between a sprain and a strain. Management include treat it as if it's fractured until proven otherwise. Don't allow them to bear weight. Assess CMS, apply splints, and then reassess CMS, and ice would be appropriate as well. Abrasions, where the outer skin layer is damaged, there's usually little or no bleeding. There may be some capillary oozing. They can be very painful. They can become contaminated and infected, and management is just to clean and cover with a dry, sterile dressing. Lacerations can be superficial or deep. They can be linear, like an incision or a cut, or stellate, meaning really jagged edges. And when you're dealing with a laceration, particularly of the scalp, you want to assess for other types of trauma, like head trauma. And here's a variety of different types of lacerations. Incisions is something that's very smooth, even edges, knife wounds, scalpels, sharp pieces of metal like sheet metal will cause incisions. Management of lacerations, incisions includes stop the bleeding, look for other serious life threats, and keep the wound clean and covered with a sterile dressing. Here's an example of an incision in the neck. Avulsions, where there's a flap of tissue. We see these with degloving injuries, ring injuries. They may bleed profusely. They may be major, they may be minor, they may be partial, where the flap is still attached to the extremity, or they may be complete, where it's completely torn away. Amputations is the complete removal of an extremity or an appendage. Usually involves jagged skin, tissue, and bone. It may not require a tourniquet because if it's a complete amputation, oftentimes the vessels, which are muscular, will pull themselves back up into the wound and seal themselves off. But obviously, if you arrive there and there's significant bleeding with the amputation, your first choice would be tourniquet. And here's an example of several different types of amputations. Management of avulsions and amputations. Consider the possibility of reimplantation, so bring the tissue with. Don't delay transport to find the part. Take them to an appropriate trauma care facility. Place the tissues in the normal position if they're still attached. Dress and bandage with clean, sterile dressings. If it's a stump, you may want to use a moist dressing so that it doesn't stick to the stump. Wrap the part in moist, sterile dressing. Seal it in a plastic bag. This would be the amputated part, or the avulsed part. And then put it in a bag that contains cool but not frozen water. One of the skills that certainly we should be able to do is to care for a amputated part. Open soft tissue injuries include punctures or penetrations. They can be caused by knives, gunshot wounds. There may be minimal to major bleeding, but be more concerned with internal bleeding. If they're not bleeding a lot on the outside of the body, they certainly may have significant bleeding going on inside. Chest cavity punctures can cause a pneumothorax, a hemothorax, a sucking chest wound. And if you've got a sucking chest wound, you're going to seal it immediately with your gloved hand until you can get something taped over the wound. Could cause a pericardial tamponade, lacerate the aorta, lacerate subclavian arteries. The injuries can also include esophageal and diaphragmatic or bronchus lacerations as well. Assess it, determine the size of the potential puncture or penetration, and treat for shock appropriately. Abdominal lacerations. Remember, inside the abdomen you've got solid and hollow organs that can be lacerated or ruptured. If it's a hollow organ, the digestive system contents can be spilled into the abdomen, resulting in a bacterial infection and an immediate peritonitis. If the intestines are exiting the cavity, in other words, you've got an evisceration, cover that with a sterile, moist dressing and protect heat from heat loss and treat for shock. Management of punctures and penetrations. Again, control external hemorrhage, assess for life threats, identify the object that caused the injury, notify police if it's a crime. High pressure injections may really appear to be very small wounds, and here we're talking about a hydraulic line that ruptures or a hydraulic line that has a hole in it. That hydraulic fluid, in addition to being extremely hot, comes out of there at 5,000-6,000 psi and can inject that hydraulic fluid deep into the tissue of the body, which can be extremely painful for the patient, may require debridement, may require lancing and opening the wound up for irrigation. Impaled objects, we leave them in place. Nothing's changed there. We don't want to remove the impaled object in the chance that we may increase hemorrhage. One of the things you should practice in lab, of course, is the care for an impaled object. Major arterial lacerations, you're going to see bright red blood. It's going to spurt. If it's venous, it's going to flow rapidly with every beat of the heart. Will quickly lead to shock and death. Management includes stopping the bleeding with tourniquets and or direct pressure. Crush injuries is when we have a destruction or damage of large areas of tissue. With crush injuries, there's always an increased risk of infection. These muscles within these areas that can become crushed, they do have a sheath around them, and if that sheath isn't ruptured or torn, then fluid can enter into those compartments, causing a compartment syndrome. When muscles are damaged, a condition known as rhabdomyolysis occurs. Damaged muscle has a tendency to not only leak lots of fluid out of it, but also leak what's called myoglobin, which will plug up the kidneys and cause an acute renal failure. Crush injuries occur as a result of traumatic asphyxia. The external bleeding may be minimal, but you may have severe internal organ damage. Prolonged crushing impairs normal metabolic function and leads to metabolic acidosis, along with the rhabdomyolysis, along with the severe volume loss, as the muscles leak not only myoglobin but lots of fluid. Restoration of blood flow is going to bring fresh oxygen in contact with the cells and bring oxygen-free radicals and the oxygen superoxide radical. And these attack cell membranes through lipid peroxidation, and then the membranes become permeable to ions and water. This further stretches the cells. The cells fill up with water. They fill up with calcium. It causes mitochondrial swelling, and the cell bursts and dies. And it's all the result of water, sodium, and calcium moving quickly into the cell, causing a swelling and dysfunction of the cell until it bursts. Rhabdomyolysis, here they're talking about that myoglobinemia, is a result in rhabdomyolysis where myoglobin is released into the blood. This also causes an increase in potassium as well as a decrease in calcium and hypovolemia. Toxins in the blood lead to renal failure, as I had mentioned. Disseminating intravascular coagulation causes thrombi to form in the kidneys. So little blood clots form in the kidneys as well, in addition to this thick myoglobin. Catecholamines also decrease kidney blood flow, and the whole result of myoglobinemia is a very nephrotoxic effect. In other words, it's very hard on the kidneys and leads to renal failure. Compartment syndrome occurs when there's an increased pressure within a muscle compartment. The muscle fascia is fibrous, it does not stretch, and when you add liquid inside there as a result of injury, that's going to squeeze that muscle. It's going to decrease blood flow to the muscle and can actually cause the muscle to die. And here's just a slide showing the influx of sodium and potassium and calcium and the things that occur as a result of soft tissue crush injury. The cause of compartment syndrome include limb compression, constrictions from dressings or casts, circumferential burns, thermal injuries, frostbite, snake bites, hemorrhage or orthopedic injuries, IV infiltration, or anticoagulation, where blood is allowed to flow into the soft tissue. The 6 P's are ideas or things or signs and symptoms that you might see in somebody with a compartment syndrome. They may have pain that's really out of proportion to the injury. They may have paresthesia, paralysis, puffiness, pallor, and pulselessness, which is a very late sign in compartment syndrome. The limb may appear normal initially, but may develop paralysis and sensory loss. The joint distal may have rigor. The skin may be taut or wood-like, and there may be pain, swelling, and sensory changes, weakness, increased pain whenever you move the extremity as well. With compartment syndrome, voluntary muscle contraction may be absent. They may not be able to move their extremity at all, and the progression will involve looking and seeing those 6 P's. Fasciotomy is used to relieve the pressure, and surgery is the only definitive treatment for compartment syndrome. Crush syndrome, you got to prevent sudden death. You got to prevent renal failure and try to salvage the limbs. You want to initiate care early in a crush injury. If a person is crushed and they're in there for more than half an hour, you know that there's going to be a lot of toxins released on the lift. So in certain protocols, they will ask that you administer calcium, you administer sodium bicarbonate, you give them fluid boluses. You do all these things before the lift, which may prevent the patient from going into cardiac arrest. Manage the patient's ABCs with crush syndrome. Maintain renal function by giving fluid boluses anywhere from 1 liter to 1.5 liters. Alkalinization of the urine is not something that we would do, but certainly something that may be considered being done at the hospital, unless your local protocol calls for administering sodium bicarbonate. Open injury risks crush syndrome and infection. In addition to open injuries, you're going to have gross decontamination necessary. Put sterile dressings and bandages over it. Get them to the emergency department. We don't use hyperbaric therapy around here, but typically it can be used to promote healing in wounds of this nature, because it pushes or forces oxygen into the tissue, which aids in healing. Blast injuries are going to cause damage due to the pressure field or the pressure wave, this supersonic wave of pressure that emits out from the center of the blast. Bacterial skin infections you may see as well. I'm going to go back to blast injuries quickly. The soft tissue injuries, initially you're going to see a primary injury, which is going to include compression of all the compartments that contain air. So you can have ruptured eardrums, you could have ruptured colon if it's got any flatus in it. You can have burns as a result of the heat that's associated with that blast wave. And then if shrapnel's involved, you can have shrapnel wounds. And then if the wind throws you to the ground, you can have injuries from being thrown hard to the ground. And then if you have any sort of medical conditions, breathing in all that dust and fumes may exacerbate your medical condition as well. Bacterial skin infections. Folliculitis is an infection of the hair follicle. Furuncles are folliculitis that spreads. So if you've got multiple infected hair follicles, those are called furuncles. And carbuncles are several furuncles. And those are typically caused by a bacterial infection, Staphylococcus aureus. Bacterial skin infections also include cellulitis, which is a local infection common in diabetes or those who are immunosuppressed. May involve the lymph nodes and or bacteremia. Necrotizing cellulitis, the skin and the soft subcutaneous tissues after recent trauma or surgery may occur, or it may develop spontaneously in patients with diabetes mellitus. Necrotizing fasciitis is a typical polymicrobial infection of the fascia following trauma, surgery, or a bite. Gas gangrene is a life-threatening Clostridium infection. You see this in patients who are immunocompromised. The incubation period for gas gangrene is about 3 days. In the initial presentation, the patient may complain of a heaviness of the affected area, brawny edema, dark colored edema, pain out of proportion to the injury. It progresses as toxins are released, causing cellular destruction. If it gets into the systemic system, into the blood supply, it can cause toxicity, cardiodepression. The extremity develops a bronze or brown discoloration that has a very foul, purulent discharge. You may see blisters. They may have a fever, tachycardia, and disoriented, particularly if it's causing septicemia. Treatment is surgical debridement. They often have to amputate in that particular case. For us, we're dealing with the septicemia or the sepsis. So aggressive fluid resuscitation, keep them warm, keep them flat, that sort of thing. Viral infections may include herpes simplex virus. Uh, Infections in the mouth are caused by herpes simplex virus 1, and infections in the genitals are caused by herpes virus simplex 2. Causes include stress, ultraviolet light, skin irritation, fever, fatigue, will all cause, the infections in the mouth are often referred to as canker sores or cold sores, where those in the genital are just referred to as genital herpes. And here's an example of the herpes simplex virus 1. It's going to present with a rash, maybe some tingling, increased sensitivity, burning, viral shedding. In other words, the virus, particularly if there are blisters and those blisters are full of liquid, if those blisters pop, that virus will shed out of that into the surrounding tissue, into anybody who touches that. So this is highly, highly contagious. There is no cure for it. To alleviate some of the symptoms, there may be some topical creams, some antiviral agents that could be given, but your best defense against this is personal protective equipment, frequent hand washing. Herpes zoster is the shingles. Herpes varicella is the chickenpox. When you get these herpes viruses, they lie dormant in and along the root ganglia of a nerve, a dorsal root ganglia of a dermatome, and later they react. And when they do react, they erupt. As a result, they're very painful, they itch, they weep, and again, a lot of viral shedding when those blisters break and leak the fluid out. You can put compresses on the shingles. You can calamine lotion to help dry them up, baking soda to help dry them up. And here's an example of shingles. You note that it's only on one side of the body, and that is particular with a person with shingles, is that it will follow a dermatome, usually on one side of the body. I mean, it can be on both sides, but typically it may present like this. And while this doesn't look too offensive, it is extremely itchy, extremely painful. It burns quite a bit. And what you see here is occurring inside the body as well. As a result, patients with herpes zoster, like in this particular patient, they would have had some complaints of chest pain and burning and itchiness without the presence of the rash, because it would have been going on inside first before it made its way outside. Hand infections mostly result from Staphylococcus or Streptococcus. In those particular situations, we want to do some gross wound decontamination. You'll see hand infections perhaps in IV drug abusers. You'll see hand infections as a result of human or animal bites. And in those cases, personal protective equipment, splint the hand in the position of comfort, and have them seek medical attention. Paranesia is an infection of the lateral nail fold, and it may involve the cuticle. You'll see it in people who nail bite a lot, in pedicures, manicures, where the equipment is contaminated. We'll see it in hangnails. Again, it's usually the result of Staphylococcus aureus or Streptococcus or a Pseudomonas. Treatment is going to be warm soaks, elevation, topical antibiotics. Not really any reason for an ambulance. And here's just a picture of the swelling and where the this infection occurs. Felon is a subcutaneous infection of the pulp space, or felon, however you want to say that. Throbbing pain, red, tense, finger pads. Surgical incision to drain the abscess is what has to happen. If left untreated, it could infect the bone, causing an osteomyelitis. And here they're just showing you the incision posterior to the digital artery and nerve in order to allow that abscess to leak out. Flexor tenosynovitis Involves the tendon sheath. There'll be tenderness, systemic swelling, pain with passive extension, flex posture of the finger at rest, because that's going to be the most comfortable for them. It is a surgical emergency. It requires a hand surgeon, so we would need to identify that this is what they're having and that they need to get to a hand surgeon. And here they're showing you or illustrating the tendon sheaths and the bursas that cover the muscles in the fingers and the hand, and they can become inflamed. You're retracting the finger, causing the intense pain, that sort of thing. Deep space infections occur deep in the dorsal part of the hand. You can get some tenderness, some induration. You can get pus, pain with range of motion. To treat it, you immobilize it, elevate it, and transfer for surgical consult. Good hand hygiene, we've mentioned this already, is paramount in preventing you from getting some of these infections that patients may have with soft tissue. So good wound care includes wearing clean gloves, practicing aseptic technique, removing and gross decontamination of debris, and then covering with a dry, sterile dressing, and then removing your gloves and washing your hands. Some general management of soft tissue trauma includes size up the scene, treat the underlying injuries before you treat superficial wounds, control hemorrhage, and that may be one of the first things you go to depending upon how serious it is. Treat for shock by lying flat, keeping them warm, controlling hemorrhage, and consider the administration of fluids. You can have different types of dressings and bandages. You can have sterile dressings, you can have non-sterile dressings, you can have occlusive dressings, adherent dressings, non-adherent dressings, wet dressings, dry dressings. But a dressing is something that goes over a wound, and a bandage holds a dressing into place. Sterile dressings may be chemically or radiologically rendered free of bacteria, and you want to put those over a wound and apply direct fingertip pressure to help you control hemorrhage. Non-sterile dressings are clean, but they're not completely free of bacteria, and they're used to provide bulk for bleeding control. You want to clean the dirt and the debris away from the intact skin first. Where I see non-sterile dressings being used is major burns, and you take out a burn sheet. If you don't have a sterile one, you just use a sheet that's in the rig. Occlusive dressings prevent the flow of air through them. They're good for large artery neck wounds where blood flowing through that artery may pull air into the chest. They're good to seal sucking chest wounds. They may have a plastic sheeting. They're going to minimize air entrance into the pleural space, but when you tape all four sides down, the patient may develop a pneumothorax and may evolve into a tension pneumothorax, but at that time you would just either needle the chest or open up the dressing. Opening the dressing doesn't always release the pressure of a tension pneumothorax, especially if by sealing that wound it has sealed itself back up. You may still have to needle the chest. Adherent dressings become incorporated into the clot. Scab will form over the wound, and adherent dressings help you control hemorrhage. Adherent dressings are packed into the wound. Non-adherent dressings, that's what we put over a burn for a burn patient. They allow the wound exudates to pass out of the wound and into the dressing, preventing gross decontamination. Wet dressings are used when you have eviscerations. Soak some sterile saline, put it over the evisceration, but remember to protect them from heat loss because they'll be losing a significant amount of heat out of their abdomen. Complications of dressings, too little or too much pressure, removing the bandages to see if the bleeding is stopped. If the bandage is too loose, they may continue to hemorrhage. If the bandage is too tight, it may restrict circulation or damage the underlying structures, but that's of no concern if there is a definite need for a tourniquet. Irrigate gross contamination, and then in your lab, certainly you'll have opportunities to practice bandaging like they do in the pictures here. And again, more bandaging here of the head and the elbow and the shoulder and under the arm, that sort of thing. Bandaging, I've always said, is an art, and it requires practice. Documentation of soft tissue injuries is a crucial part of your care. You want to give a careful description of the injuries and the patient's response to your treatment, as well as vital signs throughout. And with that, I know it was quick, but in this part in your career, I'm certain you know plenty about soft tissue injuries and the management of those types of injuries. So with that, I'm going to shut down, and I'll talk to you soon.